Good morning. So today my talk is on surgery versus SBRT for early stage lung cancer. So as we all know, surgery is the gold standard for treating early stage lung cancer, and radiation is usually reserved for older patients or patients with comorbidities. SBRT, or sometimes people also known as SABR, which is stereotactic ablative radiotherapy. It's again is only for medically inoperable early stage lung cancer. So the current standard is to get surgery, and with more and more information coming out about SBRT, we want to look at how actually they perform. People who underwent SBRT, whether they would survive, has a similar survival as surgery. So in the early 2000s, there were some randomized controlled trials looking at SBRT versus surgery for early stage lung cancer. When you look at these trials here, the targeted enrollment were close to 1,000, and here it's for 400 participants. But all these trials have problem of accruing patients. All of them has reached less than 4% accrual actual enrollment, and therefore at the end they terminated all these randomized control trial. So after those failed trials, some researchers have tried to pull at least 2 of these randomized control trials to come up with some result. And here is a paper in 2015, and the author tried to draw conclusions from pulling those 2 trials. And here it presented that SBRT could be a viable option. There are higher 3-year overall survival among SBRT patients and similar recurrence-free survival between the 2 arms. However, there are criticism saying that although you pull 2 trials, but their sample size are still very small, and the follow-up period is very short. So after that, there are a lot of studies, non-randomized control trials trying to answer the same question, a lot of systematic review, meta-analysis, and comparative effectiveness studies to address these questions. But a lot of them, the results are non-definitive. And there's still a remaining push of doing more randomized trial to answer this question. So currently there are 3 randomized trials ongoing and that I can find. The first, all of them has look at stage 1 lung cancer. One of them is limited to 3 centimeter or less. The stable mates is less than 4 centimeter, and the Valor trial, who you will hear from Dr. Moganagi later on, included tumors up to 5 centimeter. And the endpoints for the last 2 trials is overall survival. So in I-ELCAP, we have also tried to use our cohort to answer this question. Early in 2014 and later on also in 2019, we have tried to look at our clinical stage 1 non-small cell lung cancer patients in our cohort and see how many of them underwent SBRT and look at the survival. In the first paper, we have only 12 patients with underwent SBRT, but we see that the survival is very high, it's 90%. And then when we look at it later on, we have more patients, but still pretty small, 31 patients. We see that survival for lung cancer specific survival at that time for surgery was 90% and 95% for SBRT. No statistical significant difference between the 2 treatment. So there are other observation studies trying to answer this question. And here, there's a study from the Netherlands, including cases from 12 hospitals, clinical stage 1 non-small cell lung cancer. They're comparing minimally invasive lobectomy. They have about 356 cases compared to SBRT, 241 cases. We know that the unadjusted survival, they are going to be different, as we know that SBRT patients tend to have more comorbidities. So they did find that surgery, patients who underwent surgery had a better survival, both in overall progression-free survival and also lung cancer specific survival compared to SBRT. However, once you adjust it for all these comorbidity and other baseline differences between these 2 cohorts, cohort of patients. So using propensity score weighting, they no longer find any significant difference in survival between minimally invasive lobectomy and SBRT. So their take-home message at that time was the study was underpowered to detect the differences, even though they use propensity score match weighting, and they need more sample, have more patients to have a conclusive answer. So in 2023, we use both our I-ELCAP and ELCART study here to try to get at this answer again. At that time, we pulled these two cohorts, and we have up to we have 112 SBRT patients and a little over 1,000 surgical patients in this cohort. And here is a flow chart of, you can see how many patients. We have 525 patients from the I-ELCAP side, either way including, and 590 patients in the ELCART side that we're including. And these are the distribution of surgery, SBRT, and also by how many of them were solid and subsolid lesion. So this is the Kaplan-Meier survival curve for 5 years and 10 years, comparing the SBRT versus surgery, looking at the lung cancer specific survival. So as we can see that in 5 years, the lung cancer specific survival for surgery was 94% and SBRT 93%, not statistically significantly different. And then when we follow up longer, at 10 years, surgery was 90% and SBRT 88%, no difference between these two survival. We try to, as we know that the population are probably different between these two treatment groups, so we try to also do propensity score matching. We tried doing 1-to-1 matching and also 1-to-2 matching to answer this question. And we also separately try to look at the answer using both cohort together, I-ELCAP and I-ELCART combined, and also separately, look at them separately with only I-ELCAP and ELCART. And again, the results are very consistent with the Kaplan-Meier survival. There's no significantly different difference in both in lung cancer specific survival between these two groups. So we also look at all-cause survival. This is the all-cause survival for both SBRT and surgery. And then as you can see, we also separated it by I-ELCAP and ELCART here. ELCAP has a much longer survival, because we follow up much longer follow-up time as we started that study earlier. And ELCART, we just started in 2016. So you can see that the lines are shorter. But again, here we see for the all-cause survival, the 5-year and the 10-year for the SBRT group, they are much lower. Next up, again, we try to do propensity score matching for looking at the all-cause survival or comparison. We see that as we see in the Kaplan-Meier survival, when it's unadjusted, these two groups are significantly different. But once we do propensity score matching, they're no longer different, both in the combined group and also separately for I-ELCAP and also ELCART. So a year after our study published, actually, this is the study, the Netherlands studies that I mentioned earlier. They said that they need to accrue more patients, and they actually published another article a year after our studies. So they now have increased from 12 hospitals from 2014 to 2015, and now they have 38 hospitals from extended 1 year to 2016. So they look at 5-year regional recurrence and distant metastases. Between these two groups, they find higher recurrence and distant metastases than the SBRT group. And when they look at local recurrence, the two groups are pretty similar. And as expected, that unadjusted survival, we see that patients who underwent lobectomy had a better survival compared to SBRT. But once they adjusted for propensity score weighting and the multivariable analysis, they're no longer significantly different between SBRT and surgery. So the conclusion is, their conclusion is further studies should focus on optimizing and patient selection for surgery and SBRT to further reduce mortality and morbidity after minimally invasive lobectomy and nodal failure after SBRT. So I'm gonna end this talk with this presentation just about 2 weeks ago in the Astro conference. This is a revised STARS trial, which is one of the earlier SBRT trials that we saw that failed, but they continue to follow. They revised the trial and has been following up these patients. They have a total of 80 patients under an SBRT and 80 patients who had surgery. After a median follow-up of 8.3 years, they found that there's no significant difference in the overall survival, lung cancer specific survival, and recurrence-free survival between the SBRT group and the surgery group, as you can see here, and survival rates here. So in summary, lung cancer specific survival is comparable for less than 2 centimeter stage 1 non-small cell lung cancer treated with surgery or SBRT. And we observed that overall survival, they were when it's unadjusted, you see differences between the group, but once you do propensity score matching, the differences disappeared. So it supports that SBRT can be an alternative treatment option for small early stage lung cancer. And we also in I-ELCAP looking at the survival curve when we separate cases from between solid and subsolid, we did see a difference in survival between these cases. So we suggested future studies should also consider nodule consistency. And we're currently extending, trying to get more cases as to increase the sample size and looking at the treatment effectiveness for these cases, and also looking at who is going to have better improved response for SBRT. Thank you.